morning, everybody who's joining us online. We are getting situated here in person, so give us a few more minutes. We have folks still kind of trickling in due to the rain. For those that came in person and had to obviously drive through the rain. So we're giving them a few more minutes to show up. So hang tight. We'll get started here at 10:05. And Jasmine, can you hear us? I had everybody on mute, so that's probably why you couldn't hear us. You could hear us now, right? Jasmine? Okay, perfect. Wonderful. Thank you. All right. Good morning, everybody. How's everybody doing? Welcome for those of you that are joining us online. We're about to get started here with our regional meeting for the Inland Empire Community Health Initiative Rural Health Task Force. So I'm Alejandro Espinoza. We'll start with a brief round of introductions of folks that are here in person, and then we'll do a round of introductions to see who's joining us online. So as I mentioned, my name is Alejandro Espinoza, and I'm the Chief of Community Engagement for the Desert Healthcare District and Foundation. And next to me, we have.
Good morning, I'm Victoria Stephen. I'm the consultant for the Inland Empire Community Health Initiative, and you'll learn more about the IEHI in a few minutes. Thank you.
Good morning, my name is Alex Bravo. I'm the Community Engagement Manager with Molina Healthcare of California.
Hi, everyone. Good morning. I'm Nita Allen-Gadden. I'm the Associate VP for the Healthcare Services team at Molina Healthcare of California.
Good morning, everyone. My name is Vanessa Reyes from Latino Commission. Riverside Latino Commission.
My name is Mark Wirtz. I'm the Chief Operating Officer for Titanium Healthcare.
Good morning, everyone. My name is Aurelia Zamaripa, and I am the manager for the Enhanced Care Management Program at IEHP.
Good morning, I'm Chris Christensen, the interim Chief Executive Officer of the Desert Healthcare District and Foundation.
Wonderful. Now we'll kick it over to some folks that are online. We'll start off with Chris. Can you please introduce yourself?
Hi, everyone. My name is Chris Darbee with Inland SoCal United Way and 211 Plus. I'm the Executive Director of Impact there.
Wonderful, great. Thank you for joining us, Chris. April, can you please introduce yourselves?
Hi there, good morning. My name is April and I am with American Lung Association.
Wonderful, thank you for joining us. Danielle, can you please introduce yourself?
Sure. Hi, good morning, everyone. I'm Danielle Kilshenstein. I'm the Executive Director of Government Relations at Inland SoCal United Way.
Wonderful, thank you for joining us. Jasmine, can you please introduce yourself? All right, we'll wait for Jasmine. How about Carla? Can you please introduce yourself?
Hello, good morning, everyone. My name is Carla Argandoña, and I'm an analyst here at IEHP.
Perfect. Carla Flores, can you please introduce yourself? We got two Carlas.
Good morning, everyone. My name is Carla Flores. I'm with the John F. Kennedy Memorial Foundation.
Thank you, Carla, for joining us. Janice, can you please introduce yourself?
Sure. Good morning, everybody. I'm Janice Deloria with San Bernardino County Medical Society. I'm the Physician Relations Manager here.
Great. Thank you for joining us. Bernardo, can you please introduce yourself?
Good morning, everybody. I'm with HARC. I'm a researcher here in Palm Desert.
Wonderful. Thank you, Bernardo, for joining us. Sandy, can you introduce yourself?
Sure. Good morning, everyone. Sandy Sanchez with the Community Health Association Inland Southern Region, where I do policy and government affairs for the association.
Wonderful. Thank you, Sandy, for joining us. And then our wonderful crew there at the Desert Healthcare District in a conference room. Can you introduce yourselves, please?
Hi, Alejandro. It's Donna Craig, Chief Program Officer. We have Megan Kane, who's Senior Program Officer, Behavioral Health. Janet True, Senior Program Officer. I'm sorry. Megan Connie, Senior Program Officer, Public Health. Janet True, Senior Program Officer, Behavior Health. And Erica Husky, Grants Manager.
Wonderful. Okay, and then I believe Jasmine is back with us. So Jasmine, can you introduce yourself?
Hi, sorry about that. This is Yasmin with the American Lung Association, and I'm covering Palm Desert and Cathedral City.
Wonderful. Thank you, everybody. And then we have 3 new attendees that just joined us in person. Vanessa, can you introduce your team?
Oh, hello. Yeah, this is my team. We're from Minnesota, and we're doing the homework.
So we have Esperanza Sotelo, Domitila Clemente, and Vanessa Serrano. Yes, wonderful. Thank you. Thank you, everybody, for joining us. Well, thank you. This is part of the work that we're doing in collaboration with IECHI. And today we're very fortunate to be able to host this meeting here in person in Palm Desert. And for those of you that are also joining us in virtually on Zoom, thank you for joining us. So I'll kick it over to Victoria. She has a PowerPoint. Let me get that started for her. She's going to give us a little bit of background of what do we do at IECHI. So let me load that up and then I'll share it with y'all online. Sorry, we're having some technical difficulties. Okay. Can y'all see it online? The presentation?
No.
No. Okay, give us one quick second. We'll figure out what's going on. Denise, can you share it on your end?
I don't have that. So if you
Okay.
want to send it to me, I can try to pull it up.
Okay, give me one quick second.
There we go.
There we go, yay. Sorry about that, it's always something with technology, so let me just minimize this, perfect, can you all still see it?
Yes, we can see it.
Yes.
Perfect. Okay, wonderful, yeah, just cross there.
Good morning, everybody,
Morning.
virtually and in person. These hybrid meetings are an amazing experience. First, I want to give credit to Janice, who's our behind the scenes guru. So those of you who are virtual, you probably are familiar with Janice. She's with the San Bernardino County Medical Society and their CEO's right-hand person. And so thank you very much, Janice, for spending your time with us this morning and doing all the wizardry behind the scenes. I don't understand any of this, so, you know.
Happy to help, Victoria.
So I wanted to give you a little bit of an overview of what who IECHI is. Some of you are very familiar and some of you may never have heard of us before. So IECHI stands for the Inland Empire Community Health Initiative. It was started around 2008 by a couple of agencies actually in San Bernardino County starting. And IEHP was part of the original team. The Community Foundation was part of the original team, First Five of San Bernardino. And it came out of a need to continue serving children who needed healthcare coverage. And so now, a number of years later, it's expanded to 2 counties and just recently became a nonprofit. And so we're pleased with that. So briefly, our vision is to be a leader in health advocacy for children and families in the Inland Empire. And to ensure that all children, families, and now we've added adults and seniors, have health coverage and access to care. So our mission is to ensure that all children, families, and adults in Riverside and San Bernardino County have access to affordable quality health care and services. So what does that mean? We work in several areas. We do advocacy, and you'll learn a little bit more of that in a minute. We do outreach and enrollment, usually in partnership with other collaborative agencies in the Inland Empire, and also with different funding sources. We also do research, data analysis, and this actually meeting is part of one of the research studies that we did in 2018. We do governance structures and sustainability, our directions and goals. Our executive board has 6 members on it. Allison Elsner is the chair with San Bernardino Medical Society. Alejandro Bravo from Molina, who's here today and will be presenting a little later. Kevin Mahany from Family Assistance Program, who's on virtually, and will also be sharing a little bit about our 2008 report. Lisa Schiavano from RCOA Head Start. Ronnie Thompson for First Five San Bernardino, and Danielle Kitchenston from now the new, if I get this right, Inland Southern California United Way. And there, see, I'm right. And Danielle is also on with us today. We have an advisory council. We have 3 members at the moment. We're expanding that. Marcy Covey from IEHP, Benita Ramsey from Unity Fellowship, and Adrian Savala from Neighborhood Healthcare Clinics. We have a large group of members and our agencies that work with us, partner with us, and do just a variety of services and partner with the IEHI's grants and others. So I briefly told you, we originally were started as a program to continue enrolling children in Medi-Cal. And since then, we have expanded from San Bernardino County to Riverside County, and we have expanded from just doing enrollment to a variety of other services and programs. We are part of one of 32, I now believe, CHIs in the state of California. So we do have a state organization that we work with, the California Community Health Initiative up in Sacramento. And so between the state and all of our partners throughout the state and what we do in the Inland Empire, we have a pretty large reach in ensuring that children, families, adults, and seniors have health care and access to services, as well as advocacy work, and then specific needs and challenges in each area, out of which this meeting today is part of what we've been doing in the Inland Empire. We have two task force. We have the advocacy task force, and I mentioned Danielle Kitchenson from United Way. She is our chair of our advocacy and does an amazing job. We meet monthly, virtually, on the second Tuesday at noon. If any of you are interested in joining the task force, contact Danielle, or you can contact me. We do a variety of things. We sponsor a legislative forum every year, which actually was started by Supervisor Perez when he was on our board and on our advocacy task force. Between being the assembly person and being the supervisor, he was with Borrego and he served with us. So the legislative forum this year will be March 22nd. You'll all get more information about that. We participate in an annual statewide Capitol Day. We maintain relationships with all our Inland Empire legislators. We track all the child and adult health legislation, federal and state, and we also keep our partners informed on what's happening legislatively. The second task force we have is the Rural Health Task Force, and this meeting is a result of that. Alejandro serves on that. With the task force has been around for quite a few years. Alex Molina's on it, IEHP has been on it. And in 2018, we did a study of Inland Empire rural areas, and Kevin's going to share that with you in a few minutes. And out of that came district meetings. And so we started out with a meeting in the high desert in Barstow before the pandemic. Then we had to kind of go on a hiatus during the pandemic. We've also had a regional meeting down in South Riverside County in the Hemet area, one up in the mountains, and this is our fourth regional meeting out in the desert. So we're very great, appreciative to Alejandro for partnering and bringing this down here to the low desert. Again, if any of you are interested in continuing, especially after today's meeting, being part of the Rural Task Force, we also meet virtually once a month on the third Wednesday at 9:30 in the morning. So just let me know and you'll be part of it. Our goals they're starting a new 3-year goal strategy, but our goal in the last 3 years has been to implement our grants. We have both a federal grant, CMS grant to enroll children and parents into Medi-Cal, and we have a state grant to enroll seniors 50 and above and those 65 and above into Medi-Cal and also Medicare, support Medicare, to continue our advocacy efforts and to continue supporting the dialogue regarding gaps in healthcare. And that's a lot of what the IEHI does. We look at what's missing and we convene dialogue around that. And that's actually how the Rural Health Task Force got started. We realized there was not enough information and not enough work in the rural areas of the 2 counties. So how you can become part of our partnership with us, attend our quarterly health education meetings. Our next one will be in May. Attend our annual legislative forum. As I said, that'll be March 22nd. Join one of our task forces and become one of our partners in our enrollment outreach and enrollment efforts. This is Allison's contact and my contact information. So any questions, comments, thoughts?
Can you leave that contact information up one time?
There you go.
Thank you.
Okay, that was too fast, huh? So if there's any questions or anything, I'll take a few questions or comments now. Otherwise, you know how to get a hold of me. And we would love to see any of you participate either in the advocacy task force or the Rural Health Task Force. You will all be getting an invitation to the legislative forum. It will be virtually and possibly hybrid. We'll probably offer both options as we did for today's meeting, and then we'll see how that falls out. The topic this year is I remember it. It's the impact or I guess impact's a good word, of the healthcare workforce in the Inland Empire. Because we know that with some of the legislation, the change in hourly wage for certain healthcare workers, and then the current past legislation on enrolling everyone now 29 to 49, regardless of legal status, immigration status. We have a lot of people who are eligible for healthcare in the state and in the Inland Empire. So that's this year's topic. Our keynote speaker is Diana Fox from Reach Out. So if any of you are familiar with that organization in San Bernardino County, Diana will be setting the stage for us. And then, as in the past, if any of you have attended our legislative forums, our panel will represent the four legislative levels: California Senate, California Assembly, Inland Empire Supervisors, and our Congress people. So it's an interesting day. It was an hour and a half, and it's a very dynamic program. Okay, I'm going to close this off and turn it over to Alex for the next speaker. Thank you.
Wonderful. Thank you, Victoria. That's great information on both task forces. So, all right, let me play DJ here. And now I believe I'm going to stop sharing. And I believe, Janice, you're going to be helping out Kevin, or Kevin will give you admin access to go ahead and present the IECHI 2018 Rural Needs Report. So, Kevin Mahany.
I don't think Kevin is on yet. I know he was on checking it earlier, but I think he logged off and was going to log back on about 10:30.
Okay, perfect.
About 3 minutes.
Perfect. Well, in the meantime, I'll do my stand-up routine. So you guys are in for some good knock-knock jokes. So no, that's great. I think it's very valuable information that we just discussed on the legislative updates, especially now with the expansion. We'll be talking about CalAIM today, and then the community health workers, how they're potentially going to be very instrumental in assisting some of these federally qualified health centers manage healthcare plans. And ensuring that there's a new wave of, healthcare workers that could go out and really penetrate the community, go out into, some of the underserved areas. The great promotoras that we work with, come from the same communities that we serve. So they have those connections already pre-established. So it's going to be great to see how that comes to fruition, not only for, our local organizations, but statewide, and hopefully this spreads nationwide. So as they say, right, as California goes, so does the rest of the nation. So in the meantime, why don't we get started maybe with the next one, and then we'll wait for Kevin to come in, or does that?
We can do that, or I can give a little bit of background on the report that Kevin's going to share with you.
Perfect. Come on up.
So when the Rural Health Task Force was started, we were looking at what were the needs of the rural areas. And the first, when we convened a group of people interested in this task force, one of the things that came out, and actually we took a couple of months of discussion on this, is what was the definition of rural in the Inland Empire? And so we were saying rural was expansive sand, and the mountain people said, no. We don't have sand, but we're rural. And so the task force really had to look at what were the different definitions of rural. And I believe Alex was part of that discussion. And we had to look at different definitions. We used the HUD definition. We used the census definition. And none of those definitions really define the rural areas of the Inland Empire. So we actually had to come up with a definition of our own. And that's in the report. And then we had to figure out, we had to overlay that definition on the Inland Empire, on the 2 counties. And out of that, we came up with 6 rural regions. And you'll see when Kevin gets on, he shows you the report, that we color coded for the purpose of the report, each of the regions. So the low desert in the report is purple. So he's going to show you how to get to the report, because one of the things that came out of this is we developed a website a rural health website, which is ieruralhealth.org. And in the reports on that website, there's some data on that website, there's some research studies on that website, there's a variety of things. But in the report, when you're looking at the region, and we found that when we talk to legislators, and we do that, we take the report up to Sacramento and district office, they love the fact that it's color coded and they can find their district really quickly. And then we looked at what data do we need to look at. And so we looked at two things. We looked at health data, and then we looked at social determinants. And we actually tracked 16 social determinants from 2018 report in each of those 6 regions. And then we compared that data. And so
Kevin just.
Kevin came back on?
Yeah.
And there's my introduction to Kevin. So Kevin's going to show you what happened to the Rural Health Task Force and what it created in 2018. And the purpose of today is to do a pre-post pandemic on that data. So Kevin's going to give you the information we found in 2018, and then Chris Darbee from 211 is going to tell you what 211's finding now. Kevin. Thank you.
Oh, Kevin, you're muted.
How about, good morning, everyone. Can you hear me?
Yep.
Yeah.
Thank you, everyone. Alejandro, thank you for hosting. Victoria, thank you. I'm assuming you maybe set up this part of the presentation. We're going to take a quick drive-by of the Rural Health Report. Now, what I'm going to urge is, in the short time that I have with you, if any of you would love to look at this report, what I'd love for you to do is take a look at it and think about, if a new report was created, how could that report better serve your area? This was our first effort at the Inland Empire CHI to create a report that was specific for rural areas. I want to give thanks to our medical society. I also want to give thanks to First Five, who sponsored it. And I want to give thanks to IEHP for their work, and 211, and both the mapping and the bar graph work that's in the report is gifts provided by IEHP and 211. Sorry about that. I've got people on my phone. Sorry. So page 2 just basically gives you a rundown. And again, we formed a task force. On page 1, I just want you to know our CHI is one of 29 across the state, trying to promote coverage of folks. And that would be page 1. I know we're back on the opening report or cover. Could we go to page 3 and 4?
Denise, can you slow in just a tad bit?
There we go. So on page 3, we've got the beginnings of mapping. So what we did is our task force came together and said, let's start to map across the IE rural areas. And the first thing we needed to do as a task force is define what rural was. And so we had a team work on that. You can review it, how we decided to do it. But it was important for us to figure that out. And then we defined it. And as mentioned earlier, with the help of mapping, we were able to color code it in a way that you can see, hopefully on your screen, with that light purple color representing Riverside, 2 areas, the low desert and then the mid-south county. And so this is where, for those of you representing that Riverside area, we would love for you to kind of put your thinking cap on and give us feedback as to how could a new and improved report better serve some of the needs that have surfaced since the report was first done in 2018, which was prior to COVID. At that time, we knew that CalAIM was going to be coming, and of course it has. We were already anticipating that there was going to be a need for us to look at what communities could benefit most from transportation, or navigation assistance because of their rural nature. Could we go to the bottom of page 5? And you could just see here again that the light purple is going to be reflected of the Riverside area, and then the yellow is the South Mid. But if we go to page 5, okay, we are on 5 there, huh? Let's go to page 6. You can see that what we started to do was come up with indicators that we considered to be important for us to be looking at. In other words, what indicators could we look at or graph for these different rural areas that we color-coded across both counties? And we had a number of community partners that helped us. That's not that important. On page 15 of this report, and what we've done in the report is to start to provide a description in a narrative for each of the different regions. What I want to do is focus on Riverside, which I believe is going to be on page, there we go. Stop right there. Thank you. Bottom of page 14, we begin a description or a discussion on Riverside County. And then if you could slowly scroll up onto Riverside, here we go. Now we're finally landing on some of the mapping for the 2 areas. And if you could just keep scrolling. Good, just go nice and slow. There's our county map. Okay, we're starting to tell a story about what initially we could, typical health needs assessments, data that you see other needs assessment folks try to do, but this one's try to be more focused on rural areas. Okay, if we could scroll to the next page, thank you. Again, we're having a narrative in there about the different communities or zip codes in those purple colored areas. Could we scroll down and just keep going to like slides, maybe 21 near the end of the report? Good, good. Now in this report, in a narrative fashion, you will see for these Riverside communities some shortcomings and a recommendation that we engage community organizations local in your area to do more thoughtful work about some of the things we've seen. But we should have some bar graphs. There we go on slide 21. Now, again, this was courtesy of 211, which receives calls from your zip codes about needs. And again, light purple, or not so light purple, the purple color is a reflection in this case of transportation. And you can see, no surprise, transportation came up as an area, low desert to Blythe. And then that yellow bar as well, the mid-county. So navigators helping rural communities in those zip codes connect better with care, mobile services, mobile health services that could go out to those areas would be suggestions that we were thinking about at the IECHI earlier back in 2018. Could you scroll down a little more? And we've got a regional comparison of health services. And, you know, Victoria, I know you're familiar with this report, so don't feel bashful if you want to jump in and say anything, but these graphs just reflect different areas that we were looking at back in 2018, starting to look at the impact of social determinants on health, knowing that the state was going to start implementing a CalAIM. Thanks for scrolling down. And so here we've got health services and social determinants. And some of these bar graphs are going to be looking at insurance coverage. And an area that I'm just interested in would be our in the low desert with the expansion of Medi-Cal now. So immigration status does not matter. How effective are we in campaigns to reach out to farm worker communities, et cetera, to try to help them get coverage. And that was something we were attempting to bar graph in the 2018 report. Are there hotspots where we could focus insurance coverage help to try to get uninsured folks coverage? And certainly now with Medi-Cal fully expanded, we really shouldn't be walling off any community and saying they're not eligible for either a full Medi-Cal, or if they make a little bit too much money, get into a covered California. IEHP now offers covered California with Molina. And then finally, if they decide they don't want to go covered California, how do we help them connect with an FQHC down in your area? That's really all I've got. It looks like that bar graph right there is transportation systems by region. And again, that is, go ahead and scroll down. That's really, the results in general are just reported out here. And then some recommendations to us to connect. Some things that I just want to share with you that I think quickly are in the recommendations. One, we did not report out anything relative to addiction or homelessness. And now those are hotspot issues that weren't back in 2018. And as I think I understand through Alejandro and others, environmental and climate change are areas that are now hotspots for you, or areas that you're looking at that we were not back in 2018. And I'm done with reviewing the report, and I wish you all a wonderful rest of your meeting, in particular, any breakout discussions you have about the work in that area. Victoria, can I hand it over to you?
Thanks, Kevin. So this is the report on the ieruralhealth.org website. In addition to that, so you'll find up at the top the report so you can read it at your leisure. There's also a section next to the report that says data. And we had a gentleman from IEHP who actually did some interactive mapping. And if you want to look at that, it'll show you so you've got here, so under rural health data, up on the report, you'll see the interactive mapping, and it'll show you, again, you can drill down to the low desert area. And then you can choose what you want to see. Do you want to see IEHP PCPs? Do you want to see with the school districts? One of the things we were looking at that time was the overlay between health clinics and health services and school districts, and how many services were in a particular school district. So we were mapping that. This is another category that the task force is talking about, is after they look at updating the 2018 report, then we'll also be looking at updating these interactive maps. So we wanted you to, one, see the report, see what were some of the hot topics in 2018. Transportation was certainly one of them. School dropout was one of them in certain areas, and a variety of things. And then we wanted you to be familiar with the website so that you can continue to go on that, find the information that's there, and it continues to get updated with different relevant rural health issues. And if any of you have something that you would like to share, that you would like to have on the website, email it to me. And we can make sure, and that happens. I have to give Kevin credit. He's always really good about finding research articles someplace else or something that's relevant and sending it to me and saying, this should be good on the website. So we invite all of you to do the same thing. So Kevin, thank you so much for walking us through that.
Wonderful, that's great. So as Victoria mentioned, one of the goals, is to update that, that report here in the next, cycle, that hopefully we get, new data and more information. And that's what will be part of some of the discussion that we'll have today of as a group, to see what are some of the things that we want to see in the next upcoming report. As Kevin mentioned, one of the, emerging subjects, here these last couple of years has been environmental health, and then the impact on health, the workforce, et cetera. So those are some of the things hopefully that we could include in the next report. But now, we are gonna have, Chris Darbee from 211 Inland SoCal United Way. Did I get it right, Chris? All right.
You got it, Alejandro.
Perfect. So he's gonna present to us some data of the current rural needs for the low desert. So Chris, take it away.
Thanks, Alejandro. Thank you, Victoria. And Kevin, thank you for that quick rundown of the past report. I'm going to share in the chat a presentation. It's an interactive dashboard inside that you can click on it and you can actually get access to that dashboard. But I'm going to share my screen. So what we always get asked every time is, do you have some place where I can go and use that data or look up that data? So I actually put it on our website so everybody here in this meeting can access it later and you can go in. But I'm going to show you that dashboard right now. And just let me know if you can see my screen.
Perfect, we could.
Great. So as you can see here, I've kind of put together a dashboard for everyone to be able to use to kind of identify the needs happening out in the low desert and Coachella Valley and in those rural areas there. What I did is, as you showed, were showed on Kevin's map, those purple regions, I took those cities where those purple regions were in and just built it out into this report so you can see the different cities. So if you look at the bottom left of this dashboard, you'll see the cities of Blythe, Coachella, Desert Hot Springs, Thermal, and Thousand Palms. Those were the pink regions or the purple regions that were in that report. So what we did is we created a dashboard for you to be able to see that. And if you go onto the dashboard, you'll see on the top right, the needs categories. So you'll get a breakdown of what we call the needs categories. And it's in about 14 different areas or needs identified by heirs. And you can see it goes from housing, ranges from housing, utility assistance, food, individual, family, legal, and gives you a breakdown of all the different needs that we've seen. The data that you're seeing here is from the past year, 2023. So the report you saw was in 2018. So this is 2023 data coming out of 211 on the needs that are identified in those rural regions. And you can see a breakdown here on the very bottom graph of the needs per month as you look through that. And I'm going to show you how you can click on each one and get really a narrowed down view of all that. In the top left, you'll see kind of a breakdown of all of those needs. So once you identify, okay, this is the area I want to see, you can actually go here and you see, okay, this entire region, you can see the top 3 needs are housing, utilities, and food. If you wanted to break it out more, there's sections at each one where it has a little arrow and it takes you to a focus mode. You can actually pull it out and narrow it down even more to identify some of the needs on a further spectrum. So if we wanted to see more food, emergency food, what are they looking for? They're going to food pantries a majority of the time. So you'll see that that's the breakdown as you look at it between the different areas, and you'll be able to use that and really break it down to see that. Now I'm going to show you ways in which you can go through and filter through this report so you can get a good understanding. So we can look at the needs category. This is kind of where I start when I'm looking at this. You can see that there's several different needs categories on the right. Let's say we just want to look at housing. If you click on housing there, you get a breakdown of that chart in the pie graph, and then it actually updates on the bottom to see the different housing needs through time. If you want to do a comparison of the different needs, you can hit Control and click on the second need, and you can get a comparison of those needs there. So here we're looking at both housing and utilities, which is identified as the top 2 needs. Let's add the third need, which is food. Now we're seeing a breakdown of that need over time over the past year. You can see the light blue being housing kind of gone down. What do you see has increased through that time frame? You can see utility assistance in that dark blue increasing throughout time, and I'm going to share more in those other areas, and food kind of decreasing over the past year within those rural regions. Here you can compare quarters, but let's jump to the next page because I really want to look at it per city. So if you jump to the second page, you can see this is just for Blythe. This is just for the region of Blythe, and you can get the area of needs. I made the bar graphs on the bottom to match kind of what Kevin had on the or the IEHI had for the bar graphs on their report. And you can really get a breakdown of those needs. In Blythe, you can see here, dark blue, we're seeing an increase in utility assistance needed. Housing, let's look at the top 3 needs, knowing that they're all 3, housing and utilities and food. You can see the breakdown there, the darker charts on the bottom now. And you can see that in light blue, housing has kind of remained steady, some up, some downs, but utility assistance seems to be increasing throughout the year. So we're seeing a little bit of transition there of needs happening in the Blythe area. You can actually take this, once again, control to select multiple. So you want to look at Q1 versus Q4. Oops, sorry. Q1 versus Q4. You can see the difference of those needs from Q1, which is January through March, with Q4, which is October through December. And you can see from the beginning of the year and the change to the end of the year of those needs coming into the 2-in-1 contact center.
Wow.
Let's jump to the next page. Let's look at the city of Coachella. So here you can see top 3 needs again, housing, utilities, and food. Kind of changed over time, top 3 needs. Looking at it, so you can see here, light blue, housing, early on in the year at 91 requests. To Q4, we're at 47. So nearly half of that housing request. Once again, here though, we've seen a steady pace of utility assistance throughout the year, a little ups and downs between the months, but you can see that it kind of remained steady, didn't have that kind of increase that you saw in Blythe. You've seen it kind of more of a steady need through there. Food kind of remains steady there. So you see steady needs across, but a decrease in housing needs over from Q1 to Q3. Let's go to the next city. And now looking at this, you're looking at Desert Hot Springs. A lot more calls coming into our contact center from Desert Hot Springs. As you can see, there's increased number of requests. You can see for housing alone, we saw in the previous slide that it was 91. Here in Desert Hot Springs, we're seeing 312 requests for housing just in Q1. So you can actually really break it down and see what it looks like between quarters. So we want to look at Q1 and Q4. Between Q1 and Q4, we see nearly, I believe it's almost nearly at least a 75% jump in utility assistance between Q1 and Q4 there. You can see food at the beginning of the year kind of remains the same to the end of the year. And then we have the housing needs, kind of a little bit of a drop off there. And we will jump to the next one to see thermal. So here's thermal, a little less requests than what we see in Desert Hot Springs. Let's look at Q1 and Q4. Top 3 needs, let's look those up here. And we can see a much larger increase from Q1 to Q4 just in utility assistance. So it seems that a steady trend within the rural community seems to be utility assistance coming into the 2-in-1 contact center. Housing, a little bit of a decrease there. So maybe a transition from rental assistance to need of utility assistance within those local regions, but really taking a deep look at some of this data, you can identify some of those things and probably even kind of a pitch for a new report needed for the IEHI. Let's look at Thousand Palms. See Thousand Palms, do Q1 again, Q4. This is a huge jump in utility assistance. I want you all to see that here between Q1 and Q4, that it went from just 6 requests of utility assistance to 46. So an increase of 40 requests in that 3-month period of Q1 and Q4. You can see it kind of jumped there in Q3. So you see from Q1 at Q3, we hit an increased jump in utility assistance, and Q4 it continued to still go up. Housing needs still seeing that steady kind of decline. In our contact center, it may be due to the rental assistance program ending and seeing a decrease of some of those resources there. But you can definitely see an increase in that need for utility assistance coming from the rural area of Thousand Palms. So really, when you're looking at this report, it's available for everyone to jump in and really take a look. But let's look at here. I'd like to really look at, let's go back to that first page. And let's look at Thousand Palms, just so you can get an idea. So if we look at Thousand Palms, right, and we want to look at the top 3 needs. So the dark blue, as you can see, is that utility needs. You really see it would line up clearly if it was continued, but you see there wasn't much in July and August, and it seems September is when it hit its peak. So it hit a peak of utility assistance needed in September, October, and through December. And then you can kind of see that the housing kind of remained steady. And then when October hit, it looked like that transition. So between September and October, the need from housing to utilities made that transition. And why do I point this out? Because you can really see the trend of what's happening within those rural areas. You can see where at one point, you know, housing was a continued need. Then we just seen a quick jump and transition into utility assistance. You know, and it may be one of those trigger points, like what's going on, what's creating that transition in some of those areas that's causing that need, or that, you know, that social determinant of health. There is an increased pressure of needing to address certain resources within those communities. So that was a quick presentation. Like I said, I put it online for everyone to be able to go in and drill down and get that data and see. It's actually on our inlandsocaliuw.org website. So you can go in there, you can look at it, you can drill down that data to see what's really needed. You can see it over time. And if you do have any questions, if you also go to our website and go here to, I believe it's under 211, let's see, Riverside and San Bernardino County, there is a link somewhere to request 211 data on our website. So if you would like further data, you can actually go in here and actually, here it is, under the 211, and you go down to request 211 data. You can actually go on our website and request specific data that you would like to use or see, and you can actually get it emailed back, and our data analyst named Ani will assist you with a report of what is needed. So I'd like to stop there and just open up if there's any questions that anyone may have.
Hey, Chris, this is Alejandro.
Hey, Alejandro.
And can we get that same level of data that you just showed us for other cities that are not in that graphic that you presented to us? So, for example, can we get information like in Mecca or in Indio or in other cities here within the Coachella Valley, or is it limited just to those that you showed us?
No, we can actually get the data from any city, and for the most part, we can narrow it down to zip code, Alejandro. So we can go down to zip code if needed, kind of look up that data. And those are things that I can add to this dashboard for you all. So if you would like additional data, Alejandro, just send me an email, and I'll put my email in the chat. I know Alejandro has it, but for everyone else, my email will go in the chat. And if you have any other requests, you can make sure to send me that request and I'll get it for you. But yes, we can get it for each city there, Alejandro, as long as it's in Riverside and San Bernardino.
Okay, perfect. Sounds great. Thank you, Chris.
Welcome.
Chris, that was great. That was really, really helpful. And I'll talk to you about also putting a link so that's on the IE Rural Health website also, so that people can find it in 2 locations.
That's great. Awesome. Thank you, Chris. Really, really great information. I think always, you know, data always helps us shape and, you know, to plan, implement, you know, different strategies depending on what the data is telling us. So thank you all, you know, for putting that together and maintaining that data for us to be able to utilize through these really neat dashboards that you have created. Let me look into the chat really quick if you have any. Okay. There's pretty much, you're getting a lot of kudos on the chat, so congratulations. So great presentation. So now we're going to continue to some other presenters here, our community partners from IEHP and Molina. So we'll go ahead and load up. The dashboard requires a password. Is there a password for it, Chris, or is it something that we could bypass?
I'll look into it. There shouldn't be a password, but I'll see if I can remove that if there is one.
Awesome. Thank you, Donna, for that, for looking into that. Thank you. Okay, wonderful. So let's go ahead and move on to our other presentations from our community partners here from IEHP and Molina. So we'll go ahead and get started. I believe we do have a joint, perfect. It's combined, is it combined?
Two separate ones, I think.
It's two separate.
Yeah, I
Yes.
thought I saw mine.
Okay, oh, yes, I got it. I think we put them together.
I think it only has two slides and. Yeah, we'll be talking about that, right? Yes.
Yeah, is this Sune?
Yes.
Yes, okay, perfect. All right, so we'll go ahead and welcome Aurelia Samaripa, who is a manager of Enhanced Care ECM program at IEHP. Wonderful. All these acronyms, I tell you. Okay, let me get this up and running for you, and hopefully the folks on Zoom could see it as well. Share screen. Right. All right, can you all see the presentation?
We can.
Wonderful, perfect. All yours.
Yeah.
Mhm.
Oh, good morning, everyone. Thank you for having me here. I really appreciate it. So I wanted to talk to you a little bit about our Enhanced Care Management Program at IEHP. My name is Aurelia Zamaripa, and I am the manager for the Practice Coach section of the ECM program.
Just the arrow, I believe the arrow down.
I press the arrow and it's not.
Nope, it's not advancing.
Oh, let me see.
Sorry about that.
So what's a practice coach?
So I can talk a little bit about Practice Coach. So what we do is we have a Practice Coach program, and I'm actually the original. I take a little bit of pride in saying that I'm the original Practice Coach brought on to IEHP. We first did practice transformation, and then I was so lucky to come to first the health home programs, and now, of course, the Enhanced Care Management Program. And what we do is we partner with wonderful ECM providers, and we really work shoulder to shoulder with them. Ensuring that their practices, they're following the model of care, following the DHCS requirements. So really, what we do is just help them be successful. If they're successful, then we're successful. I have a privilege right now of having 3 practice coaches, and we will be growing to 5 more because we will be onboarding 25 new ECM providers this year. So very happy about that. That's it. Let's try it again. There we go. So of course, CalAIM came up with the care management continuum. And as you can see, ECM is the highest care management program. It's for the highest needs, highest cost patients, and following by complex care management, which is for the higher to medium rising risk patients. And then the basic population health management, which all health plans members receive the basic population health management when they are in the complex care management or the enhanced care management program. So what is enhanced care management, ECM? It's a whole person approach to comprehensive care management. It addresses the clinical and non-clinical, and this is for, like I said, for the highest need, highest cost of patients. It's an interdisciplinary, high-touch, person-centered, and it's provided through in-person. So we really push for that in-person, that personal connection. And then, of course, on DHCS version is to coordinate all care for eligible members, so including all across the board, the physical, the health, the dental needs, and of course, the social determinants of health as well. Each care team or each patient enrolled in ECM has a dedicated care manager, which the state calls the lead care manager. And ECM is to meet the populations of focus, so you need it. And patients can join or opt out at any time. So here are the populations of focus that we focus. Of course, it's individuals experiencing homelessness, or homeless families, or unaccompanied children and youth experiencing homelessness. And then, of course, it's also individuals of all ages at risk for avoidable hospital or ED. And then individuals with serious mental health or SUD, substance use disorder. And then individuals transitioning from incarceration. We first started with Riverside County, and now this year we've gone live with San Bernardino County as well. And then adults living in the community at risk for long-term care, and adults living in residential and nursing facilities wanting to transition back to the community. And then children and youth enrolled in the CCS program that have additional needs beyond the CCS condition. Children and youth involved in child welfare, and then our newest one is the birth equity population of focus. So our service delivery model offers 7 core services. So it starts with the outreach and engagement, the comprehensive assessment and care management plan, the enhanced coordination of care, the health promotion, the transitional of care, member of family support, the coordinations of referral to the community and social supports. And our ECM care team model consists of an RN care manager, a BH care manager, a care coordinator, and a community health. Just recently, we went ahead and updated. We know the challenges of having an RN, so just recently we updated it to have a highly qualified LVN to be the care manager, as long as they have clinical supervision. So here are the partnering organizations in our low desert. We have our UHS, Titanium, which is here, and we thank you for that. Indus Medical Associates, Sava, Staff, Borrego, and Intercare, which is Clínicas de Salud del Pueblo. Just a few that were contracted here. And like I said, we have 25 more coming. This is how we refer our patients right now. We are in the process of putting it online, but it's taking us a little bit longer since we implemented the Covered California. So members can call directly to member services, and they will be transferred to our care extenders. Providers can call the provider services, which is the numbers here, or they can email the care extenders directly, and then we would contact the patient and go ahead and conduct an assessment, see if they qualify for the PCM program. And then I will skip this, right?
Yeah, so it's just so you have the information. We didn't want to duplicate because a lot of the information is the same, but just referral processes are a little different. So you have our kind of referral forms where you can find them, and the contact information where that can be submitted, and also the number for our member services. They can always assist with those referrals.
Thank you. And here is one more.
And same thing, just contact information for our ECM and community supports teams, any inquiries that you may have or contracting inquiries. We just want to provide that.
Thank you. And are the slides going to be shared?
Yes, yeah, we'll share them. Yeah, we'll share them.
Thank you.
Yeah.
So thank you so much. Are there any questions? Thank you very much.
Thank you. Wonderful, wonderful.
Very exciting. Very exciting. Okay, so now we'll go ahead and let me get the other PowerPoint here ready. Okay. All right. So let's see if we can get this right. All right, so now presenting on behalf of Molina, we have Nita, who is the Associate Vice President of Healthcare Services. So let's get this. just to move along, just a little button right there. Okay, thank you.
Hi, everyone. Nita with Molina Healthcare. I'm very happy to be here today. So I'm going to talk a little bit about community supports and how I see that as a great kind of companion benefit to ECM, which Aurelia just went over. So I will advance the slide and talk a little bit about this particular aspect of CalAIM. So community supports, you may have heard of it in the past as in lieu of services. And the idea is that the state has kind of identified 4 kind of pre-approved list of services that really function in lieu of covered benefits. So it's like you would utilize this community support instead of that hospitalization or that skilled nursing facility placement. And it's designed so that you don't have that specific higher level of care, but our folks still need a certain level of care coordination and assistance in navigating, right, through some of these social determinants of health. So that's kind of the thought process in mind when we were implementing this and when the state kind of rolled this out. And we talked, there was comments were made earlier about how, we saw housing, right, as a huge concern in the past, and then it kind of went to other things. We talked about how there was kind of that shift now into environmental factors. So you'll see that in some of the community supports that I cover, where the state is kind of like paying attention and looking at that. And now these services are available to our members that really need them. So community supports went live January 1st, 2022. And by that, I mean that all the 14 services were available, but the health plans had the flexibility to kind of implement them in a phased approach. So it was every 6 months, we would go live with a different set of community support services out of the 14. So as time went on, now we're in 2024, right? 2 years later. So pretty much we're live with all 14 community supports. It's just the availability and the different, providers who are contracted in each of the regions. So we'll talk about that. But of course, the community supports, again, it's looking at medical and social determinants of health. So you'll see that as we go through the 14 and really looking at, like I said, avoiding that hospitalization or readmission or the need for nursing facility admission if we can find a different route, right? That works better for our members. These are the 14. I'm sorry, it's a little blurry when you see it on the screen. But we're gonna go through each of them. So you have your housing related ones, which are the housing transition navigation services, housing deposits, housing tenancy and sustaining services, short-term post-hospitalization, recuperative care. And then you have kind of the other ones related to like respite care for your caregivers, your day hab programs to help support members in the community. Then we have folks that are, at risk for nursing facility admission. There's the transition and diversion to assisted living facilities, or folks in the nursing facility who are ready to transition back home or back into the community. Then personal care and homemaker services for folks that need a little more assistance with ADLs, IADLs, things like that. Then EAA, which is our environmental accessibility adaptations or home modifications, like ramps and things like that, medically tailored meals, sobering centers, and then asthma remediation, which kind of ties into those environmental, factors that we're talking about earlier. So in terms of eligibility, pretty much with both of our plans, these are authorized services, like prior authorized services for the most part, except sobering centers. That service, the nature of it, right? It needs to happen immediately. You can't really wait for approval per se from the health plan. So that's more of a notification basis because you have the person right there. You need to take them to a sobering center. You need to get them some, right? So that's more of a notification after the fact. But for the other services, they do require prior authorization. So that means we have, we each have our referral forms that you would send that to. It comes into our respective community supports team. And we review, make sure the folks meet the criteria, or we may request additional information as needed. Kind of goes through that standard auth process. We have our referral forms online. You'll get the presentation, so you'll have the link and everything there. And each of the referral forms, it is one for each community support because they all have different criteria that the state specifies. And we follow exactly what is in the DHCS Community Supports Policy Guide. We cannot be more restrictive than what the state prescribes in terms of the eligibility, the services offered, and things like that for each of the community supports. And then, of course, to the best of our ability, we look for duplication of services. We need to make sure that, they're not receiving another, covered benefit that conflicts with the community supports. And the important thing is community supports are optional. These are recommended services for the members, but we're not mandating, right, that they have to do it instead of a covered benefit. But we want to make sure that folks have access, that they know it's available, and encourage those referrals coming in. Okay. So getting into each of these are kind of information heavy slides, so I won't go through like bullet by bullet on every single thing, but just to kind of give you a general idea, what is the support, who qualifies, and kind of what are the services that are entailed. So kind of the most highly utilized one for us, at least as we've seen in the past couple of years, and I think it's across the board, with the state is the Housing Transition and Navigation Services. You saw for ECM, you have that homeless population of focus, right, for the adults and the children. And that ties in kind of nicely to this community support where those folks that are part of that ECM population of focus more than likely are receiving some type of housing community supports. Most of them, it's this one, which is help actually obtaining housing, applying for housing, the benefits, the advocacy, that aspect of it, and getting those resources in place to help folks, obtain housing as the first step. So of course, the folks that are meeting the definition for homelessness or at risk of homelessness, and they have, one or more chronic conditions, SMI or mental health issues, folks that are prioritized for supportive housing or rental subsidy, those folks all, qualify. It's a pretty, broader definition. And with the housing transition navigation services, the scope of that includes, like I said, securing that housing, applying. There's always an individualized housing support plan that's created for members where the homeless services agencies will kind of go through that, make sure you're meeting all the goals as identified together in that housing support plan. And like you see, it's like arranging that housing, the coordination that's associated with that, moving in, things like that. Next, you have housing composites. So that's used a lot in conjunction with the housing transition navigation, and then you'll see housing tenancy, because this really helps with that first like move-in cost that is inherent, right, when you find a new place. So this, these are folks that are receiving the other transition navigation services. They're about to get housing, they meet that HUD definition, all of that good stuff. What it helps with is the security deposits, the first and last month rent. There is that first month coverage of utilities that's included here. And then some items to establish like the basic household. So whether, for us, it's that supplemental items, whether that's an alarm clock or, a dresser, things like that, that just help with that initial move-in cost. The limitation is that it is considered a once in a lifetime benefit. So once it's utilized, there has to be like a significant change in the condition in order for it to get approved again. But the recommended kind of state limit is $5,000. So it's like you can get approved for that service and then kind of like submit for the costs associated like in that duration. And let's say, I think a lot of these things we have to be flexible, right? So if you have a 6-month, let's say, authorization, but then some things may be delayed, move-in stuff, right? Can take a while, and you need to extend that to ensure that you get all the stuff in that time frame. That's just a call to our team. That's an outreach to us to let us know that information. We can always kind of work together to make sure that our members at the end of the day do get that support that they need upon move-in. So that's housing deposits. I'll go to housing tenancy. So once, folks obtain housing, there is that aspect of keeping that housing, right? Whether that's landlord education or, assistance with lease compliance or things like that. And that's what this is designed for. So folks that are receiving those services, again, the criteria is kind of the same in terms of who qualifies. But the services, this is really where, the role, of that provider when providing the services is to ensure that our members have the tools that they need to maintain, retain that housing once they've, actually obtained it. Now, this also is considered a once in a lifetime benefit. There has to be a real change in condition in order for it to be approved again. So those are the three that we call the housing trio, because they're kind of the most heavily utilized so far. Then we have short-term post-hospitalization. This is really for folks that are, right, again, homeless or at risk for homelessness. They don't really have a place to discharge following a hospital stay, and they need kind of a higher level of follow-up care as a result, like medical care or behavioral health care, or if it's SUD, kind of an opportunity to continue with that treatment kind of post-hospitalization, right? So you are, it is a once in a lifetime benefit, but it's not to exceed a duration of 6 months at a given time. So it's an option that's available for folks who just need that extra level of care when they discharge, higher level of care when they discharge, and don't really have a safe place to discharge to or home to discharge to. And also part of that is the allowing that recuperation recovery, post-hospitalization. So this is an avenue to allow that to happen. Next, also housing related is youth care, which of course has been around for a while. I remember, Molina, we kind of started that in 2016 with the Illumination Foundation in the IE. We kind of piloted it, and then we were happy, of course, to now see it as a community support service from the state. So really it, again, criteria is kind of the same. Folks that are at risk for homelessness or meet the criteria for homelessness, but these are also folks that are at risk for hospitalization or readmission. They have no formal supports. They're would be discharged to the streets, maybe otherwise, that kind of thing, but they need, maybe it's a 2-week period, maybe it's a little longer than that, but they need some time and a place, a safe place where they can recuperate from the hospitalization, from whatever just occurred, and get the wound care that they need, for example, or have the transportation to follow-up visits or appointments be scheduled out of their wound care center. So it's a great kind of benefit that that is available to our folks. Again, the main limitation is that you can't exceed 90 days in one stay. So that's like the max, but let's say a readmission happens or another admission happens later down the line, that's a new authorization. So it's not the same as like the once in a lifetime stuff that you saw with short-term post-hospitalization. So we see more utilization on the recoup care side. Respite services, this is for the caregivers, right? So when you think about the highest risk, highest vulnerable members, you also think about the folks that are caring for them, right? Family members most of the time. And they do need a break to avoid burnout, things like that. So the state is actually great. The state has this available as a community supports where we can provide that caregiver relief through this avenue. Now, it could be in the home, it could be in a different facility. Both of those are available. And then the limitation is just that you can't exceed 24 hours of care per day, which it would be hard to do. So that's the main limit. Day hab programs. And the day hab was designed to assist folks that are either experiencing homelessness or recently housed to kind of settle into the community. So that's acquiring, certain skills, their socialization, aspects to it, adaptive skills, kind of teaching those in either group or like workshop settings, and really kind of informing or giving folks, like I said, the tools to kind of go back into the community or integrate back into the community. And you'll see some of the services like cooking, cleaning, shopping, right? Just things that we may not think of, but really have been maybe that's something that they haven't had for a long time and need kind of that assistance or that support in getting back up there. Next, personal care and homemaker. This is also, we have seen an increase later as people become more aware of it. So for folks that are receiving, right, or in the process of receiving IHSS services and home supportive services through the county, they may have a caseworker, but let's say the hours are not enough, or they haven't gotten approved yet. They're kind of in limbo and waiting. This is a great community supports to kind of fill that gap. And like it says, folks that are at risk for hospitalization, they may be institutionalized or at risk for institutionalization in a nursing facility. They don't have that adequate support system, or their caregiver right now is not able to provide enough hours, right? And while they're pending IHSS or maybe they just didn't get the approval or they're not eligible. This is a great way. We have agencies that come in and provide that personal care services, either for a different caregiver, or we have other providers that have a different model where they will actually work with the existing caregiver and kind of supplement the services that they're able to provide, or kind of do that adjustment to just reinforce the support team that the member has. So they assist with meal prep, grocery shopping, all that kind of stuff, to really, provide that support where there may be gaps in the existing kind of framework. Then we have the community transition or nursing facility transition to home. So folks that are currently receiving that higher level of care and they're ready to kind of transition back home, back into the community. You'll see kind of the criteria here. The main thing is that they no longer need that higher level of care, right? They're able to reside safely in the community. So this is essentially kind of a housing thing to help them with that transition, because it's hard, I'm sure, to go from nursing facility just back without some level of support. Especially those folks that are becoming newly housed and may need some of that same assistance that you saw earlier with like those setup expenses, with coordinating moves and things like that. So this is designed to help with that, and especially kind of coordinating all the needs around integrating back into the community or transitioning back home after being in the nursing facility. This one also has a different type of limit. It is the state has set more of a dollar amount limit where it's a max of $7,500. But it's also one of those where we do have the ability, if something changes, again, conditions change, situations change, that comes back to the plan for review, and it can be approved an additional time based on the needs. The next one, this is also a mouthful, the nursing facility transition or diversion to ALF, assisted living facilities, or RCFBs, the residential care for elderly and adult residential facilities. So it's to help those folks, again, come back to the community, live in the community, and avoid the institutionalization aspect of it whenever possible. So you have different criteria. It's the transition to an ALF or the RCFB, and then you have diversion where you're preventing that admission too. So you see there's kind of two different eligibility criteria for each, but very closely related. And the main thing is that they're willing to make that move into the ALF or RCFB as an alternative to the nursing facility, and that they are able to reside safely, right, in those facilities. So the services really entail, again, coordinating that move, assisting with their housing needs, and presenting those options for the folks, kind of staying with them and case managing while that placement and everything is happening. And then kind of working with the facilities throughout the whole process, right? The only limitation or main thing to keep in mind is that living expenses are not covered as part of this. So your room and board, that is not kind of covered or part of like the housing aspect of this particular community support. I'm almost there, I think. So EAA talked about briefly, so this is home modifications, right? So grab bars, shower bars, things like that, wheelchair accessible things. It also covers the PERS system, so personal emergency response system. So that's also available through this benefit. And then this one also has that lifetime limit of $7,500. We haven't seen anybody so far in the past 2 years come close to this. This is also one that's getting a little bit more popular, or a little bit more utilization that we're seeing. But again, we haven't seen anybody come across that limit yet. Again, if it goes over that limit, we can review that, we can make that exception if circumstances have changed, situations have changed. Meals is one of the most popular ones. So if you look at the criteria, it's people that have been discharged from the hospital, chronic conditions, you know, all your main chronic conditions, and then just anybody that has extensive care coordination needs is eligible for meals. So they're home delivered meals, they're tailored to dietary restrictions or conditions that our members need. Some of our providers have RDs on staff to do the nutritional assessments and separate kind of assessments to evaluate and have, you know, the right food, and also provide that nutritional education and things like that. And then you have kind of the limit here for 2 meals per day, up to 4 weeks per hospitalization, max of 12 weeks per a calendar year. But again, subject to utilization, we have approved beyond that if the member's condition calls for it. Of course, we want to make that available. Then sobering centers, we kind of talked about, this does not need prior authorization, more of a notification, but really folks that are usually 18 and older and kind of meeting all these different things. And it really is to avoid that that stay overnight in jail, or maybe a little longer than overnight in jail, or to avoid that ED usage where they could go to a sobering center and sober up with ED services if they need any medical attention, mild medical attention, and things like that. Shower, things like that. Then last one, promise, is asthma remediation. So we kind of talked a little bit earlier, it was mentioned, right, about how we're paying attention to environmental factors and different conditions that could be contributing to health. And asthma was identified by the state as, okay, one condition we want to look at and we want to create something around this. So this is the asthma remediation community supports, where that involves kind of like doing an assessment at home, kind of seeing what the risk factors are. And through this, you can get, you know, dust-proof mattresses and pillow cover. You can get HEPA filters. There could even be like, if there are minor home repairs or things that are needed that could help alleviate the condition. It's just all based on like the home assessment and making the home better and more safe, preventative. So this one again has that 7,500, and I'm gonna do my same disclosure of if the condition changes, we'll look at it again. Just let us know what the deal is if it needs to be more than that. Then just a high level, I kind of went over some of this, but you know, what's not a community supports is the room and board stuff. Renovation remodeling is different from home modification, so that part is not covered. Personal living expenses like clothing, the actual groceries themselves, we can support the shopping, right, and the education there, but the actual groceries themselves, those kind of things are not related. And the food insecurity, I mean, medically tailored meals is as a result of the chronic conditions or the hospitalization. So that kind of component has to be there. And then actual detox facilities are not covered. That is still SUD, you know, covered through the county. You have our contact information. And then I also wanted to share IEHP, they also have their authorization process. They also follow the community supports guide, but this is the contact information on how, on who you can contact, and then how you can get more information by talking to their member services department for their members, and then providers to their provider services team. And then just some state resources, you know, on your spare time. There's just a wealth of resources around CalAIM for the state, so that's included there. And then I'm gonna turn it over to
really quick. And then to progress the slides, is it just this one here? Yeah. Okay, fantastic. All right, good morning, everyone. My name is Alex Bravo. I'm the Community Engagement Manager at Molina Healthcare, and I'm here to talk very briefly about a local community resource in the city of Indio. It's the Molina One-Stop Help Center, and it really started with a question during the pandemic, is how can we continue to support the community in the community? We listened not only to our community partners, but also our members. And this was kind of our vision when we thought of a community resource in the community. This is now the Indio One-Stop Help Center live. So we opened up in January. This One-Stop Help Center, it's not just for Molina members, it's for the community at large. And so today we heard a lot about utility assistance. We heard a lot about housing. We heard a lot about many different resources. And so these resources are some that folks in the community can access. I highlighted some logos down at the bottom. These are our community partners. So this is not something that we do all on our own. We rely on the community to help us. And so we're open Monday through Friday, 8:30 to 5:30. We support with stuff from enrollment. If someone needs help with their Medi-Cal redetermination, if they need help with different, I don't know, counseling services from A to Z. And so our staff is bilingual. Our community partners also bilingual. We're contracted with the language line, but really it's a community center for the community, in the community, and we welcome all. Here's a flyer. It highlights the address, our hours of operation. We're located on Highway 111, cross street is Monroe. For those of you that are familiar with the Indio area, we are in the same shopping center as Western Dental. Here's my contact information if you have any questions. I'm trying to keep it really, really brief because I'm mindful that we have other presenters, but again, a local resource that you're all welcome to utilize. For those that do a lot of field visits, and I'm kind of looking at El Sol, if you ever need space to come in, tap in and work, you're welcome to do so. Again, Monday through Friday, 8:30 to 5:30. Here's my contact information if you'd like some more information about it, or if you would like to, you know, tap in and work out of our site. Again, it's for the community. Thank you.
Wonderful. Would it be okay? I can share a quick success story as a relationship in the slow desert with Molina and IEHP, as a kind of operational side. So again, I don't want to take too much time. I'm so excited to be part of this. I'd love to get more involved. I'm in awe of everything that I'm hearing so far. So thank you for letting me be here. So yeah, we are a contracted provider for what was just discussed with Enhanced Care Management, ECM, as well as Community Support CS. And I'll tell you the need that is the volume of individuals that need these programs specifically in this area is astronomical. This is a success story. We record all of our success stories. We try to share them with our plan members. This is a success story that came out of this area specifically. This was an IEHP member, and it's entitled "Food and Warm Clothes." We had a lead care manager that connected this patient or this individual. The situation was a member had recently regained custody of her son and needed help obtaining and filling out important paperwork to get her son enrolled in school. While the community health worker was visiting the member and assisting the member, he noticed that the family did not have food in their RV trailer and that the member's son did not have winter clothes. The outcome and follow-up, the CHW was able to make a call to St. Vincent de Paul and obtain an emergency care kit of food, warm clothes for the member and her son, and toiletries. The CHW will continue to be of support and provide local resources for this member. again, the healthcare plan was IEHP. We record these on a monthly basis. I refer to all of our staff as the angels on the shoulders of the members in which we serve. There is such a dynamic need for people that, you know, they may have made one or two poor choices in their life that led them in a path that became a snowball effect. And who are we to judge them for that? You know, maybe we had an opportunity, maybe we come from a background that gives us a leg up, and maybe we made one or two positive choices that put us on a trajectory to do really, really well. And so here we are. I think it's just a practice of humility, and I think we're all examples of this, that we go into various situations without judgment, and we find out how we can help people get this leg up. You know, one of my favorite things is we track the graduation rates or the successes of when people no longer need our program. And there is no greater of a day than when my lead care managers or my regional managers come to me and say, just wanted to let you know, we call it disenrollment, but it's a disenrollment because they graduated. Where they no longer need our services because they were able to get into permanent housing, they were able to get a job, they were able to take care of their family. It's amazing. So just wanted to share that quick story, but I appreciate all of this. This is incredible stuff. Thank
This
you.
is wonderful. Thank you. Thank you for sharing that. And I think, you know, we do have some promotoras here from, you know, from El Sol that, you know, that do that kind of work, that connect, that are out there interacting with both Molina and IEHP members, and that they're connecting them with those vital services that, you know, they might be doing outreach for one particular program, but as we all know, individuals with needs will go beyond that need that you're trying to address by that program or service that you're there visiting for. And then now they need to have these resources. So thank you both for, you know, sharing that information. I think it's going to be really useful for the promotoras or the community health workers to know that information and know where to guide, you know, some of the community residents as they're interacting with them and they're identifying those specific needs. So really, really good information. And I
Tengo
think,
pregunta, Alejandro.
Mande.
Para ella, dentro de este edificio, ¿tienen también ahí quien haga las aplicaciones para el Medi-Cal y la aseguranza de ustedes?
Sí, tenemos a alguien que puede ayudar con ese proceso, es un broker, entonces puede consultar para todos los planes de salud que están disponibles en la área.
Ok, gracias.
wonderful. And we do have some questions here online. Are the slides going to be shared with everybody? We will. So if you would like to have a copy of the slides, please go ahead and type in your email in the chat, and we'll go ahead and get those to you as part of our.
Yeah, they'll be sent out to everybody who registered today
Oh, perfect.
automatically, along with the recording of this meeting.
Perfect. There you go. Awesome. Wonderful. Well, I think these last couple of minutes, these last 15 minutes or so, we want to have just an interactive, you know, discussion with folks here in the room and then those that are attending online. We are going to be asking 3 questions, and I believe Janice will be assisting us since we have a relatively small group. I think we could, you know, break out into one room there, Janice, for you know, for you monitoring and you know, doing the breakout session for those folks that are in Zoom. And then Victoria and myself will go ahead and assist the folks here with the guided discussion that is gonna focus on the 3 questions that we have in the agenda, which are: what data is the most pertinent to the low desert region that we serve? The second question is: what are the most urgent needs in the region that you serve? And then lastly, what are the next steps that you recommend for us to take as a group? So with that, Janice, you're still with us, correct? I see you. Yes. Perfect.
Yes.
Wonderful. So go ahead and guide that discussion with the Zoom attendees. And then Victoria and myself will go ahead and guide that discussion here with those folks in person. So I'm going to go ahead and mute ourselves here so you don't hear our discussion. And then you could solely focus on, you know, doing the questions with, and the moderation with those folks online.
And let's reconvene at 5 minutes to 12.
Okay, perfect. So
Get any report out for the discussion groups.
perfect. Yeah. So we'll go ahead and reconvene at 11:55 which will give us about 5 minutes for each group to go ahead and report out on their discussions and their findings. Sounds great? Awesome, perfect. Okay, I'm gonna get our mute ourselves, and then Janice, go ahead and guide the discussion amongst your group there.
Right. Hi, everybody. How is everybody today? Kevin, do you want to go ahead or no? No? Oh. Hi, does anyone would participate in this part of the task force meeting? Jana, it looks like you're the only one.
I think a lot of the issues that we saw, based
Do you want to do next steps to get? They all check?
Yeah.
Okay.
Hi, everybody.
Hello.
All right,
Hi.
good, very good. All right, so I guess, we'll do a share out of what was discussed amongst your groups. And then we'll talk about possibly some next steps. We might go a little bit over if you guys are, we do understand if you have, you know, a noon, meeting or, you know, we're holding you between you and lunch, so feel free to disconnect, but we might go just a few minutes over. So here, Victoria, you wanna, share what we discussed with the group here?
Well, I just took a few notes. So we said regarding data that housing, food and utilities, we're still seeing some of those issues. His utilities maybe because housing has been, addressed, but also with the, elimination now of housing subsidies, we may in the next few months see a change in that. An issue was the reimbursement for CalAIM support services to the CBOs contracted to do that. So the money flow issue is always a challenge and that needs to be looked at so that services continue to be provided by CBOs. Another issue was dental services were a higher need and also lag time for appointments, medical appointments. And I guess also mental health appointments. Under mental health, it was at the higher level mental health services, psychiatrists were challenging, but also looking at outreach campaigns for the communities and education for communities for the individuals to understand that mental health is as important as physical health, that they go hand in hand, and that you've got a deficit if you ask for mental health services, or are you utilizing some of those coping skills, or being taught some of those coping skills, and that there's a need more for youth services, I suspect for particularly prevention, early intervention, so that we don't move into substance abuse challenges by our youth, and we don't move into suicide challenges by our youth, or anger aggression challenges, where they take out their frustrations on others. So that was the discussion so far.
Wonderful, thank you, Victoria, for that great, summary of our discussion. Who wants to report out on the online group?
Could that be our group?
Yes.
Okay, good. Well, that was a lot of material there, Victoria. Real quick on our side, I took notes. It was raised about increased numbers or mental health. Just a discussion that there's more need there. There was also brought up about air quality, that it may have gotten worse. And so that could be an opportunity for us to look at. Internet capability came up, and there was a recommendation for us to look more carefully at broadband, its access, maybe what's happening or going on between the Coachella Economic Partnership. There was advocacy from Carla at the east side of the Coachella Valley, again about internet access, and the North Shore area. Schools have done a great job providing kiddos with hotspots and sources where they could get internet access. There was a concern again by Carla about funding for housing, particularly like Desert Charities, that they've run out of funding to try to help folks that have got or rental assistance. I hope I'm not missing anything, team, but that's what I jotted down real quick, and Victoria will provide that in writing to you for your notes.
Great, wonderful, great. Victoria, so you want to lead the discussion on the next steps?
So I'm opening up this to those on the call virtually and in person. One of the goals here when we do these regional meetings is to help the community decide where do you want to go from here? What are your next steps? And in discussion, in looking at some of the issues that have been brought up, in finding solutions for things. So I kind of opened this up to both groups, virtually and in person here. What do you recommend are your next steps after today's meeting? We're here to support and assist, but this is your community. And we find that leadership, local leadership is what gets things done. Any ideas for next steps?
I think maybe one of the things that we've been discussing is maybe updating that report. You know, the 2018 report, maybe, and adding on some of this new requests that we, both the Zoom group and the in-person group discussed. Maybe including some of those components, maybe, accessibility, lag time for appointments, and include some of those things that were also discussed online, which are the environmental health, issues and how those impact our general health and physical health. So that might be something that we want to include in updating, maybe do like a 2024 report that could possibly be released, sometime, in the summer, late fall.
Yes,
And
real.
probably, I'm sorry, and possibly include the social isolation and loneliness.
Yes.
That's becoming very common.
Yeah, we launched a
Great
program around that because it has come up with it's called PICS, there's a mobile applications like social isolation support. But that, yeah, definitely came up as.
So the Rural Health Task Force has taken that on, and that is one of their goals, one of their primary goals. We invite any of you who want to either be part of the task force or just let us know that you'd like to be part of the report development for the low desert. Because that's kind of how we do that. We'll have leads from each region. So Alejandro is your lead here for the task force for the low desert. But he'll need people, once we get to doing, collecting data and stuff, he'll need people from the low desert. So if any of you are willing to work with him, when we get to that part of the report, let him know that.
That's good.
Anything else that you'd like to do here in between while we're working on the report? Is there anything as the next steps from this meeting? Do you want to do more research? Do you want to meet again in 3 months? Do you want to work on a particular issue that was brought up in our smaller group discussions? Do you want to just share each other's contact information? What would be your next steps here?
I would love to continue to meet with you folks. I really enjoyed this. I'd like to go on that email exchange and get more involved. I think the work that's being done and the need for this work is so massive. I guess I'm a little old school. I like the idea of meeting in person. But I think there's value in brainstorming and sharing ideas and being in the same room. And kind of identifying barriers and things we're struggling with versus things that are working and succeeding. So I would love to get more involved with you folks. I'm very excited about this.
Wonderful. Great. And we have Spanish speaking in person. I just want to, for those folks on Zoom. ¿Qué les gustaría mirar ustedes como promotoras que serían los próximos pasos después de esta junta, de todo lo que hemos hablado? ¿Qué les gustaría mirar ustedes como los próximos pasos después de esta junta? De todo lo que hemos hablado.
Pues definitivamente salir a la comunidad, a dejarles el mensaje de todo lo que hay de inmediato para empezar a ver los resultados.
Yeah. Muy bueno. I think just a public awareness campaign. Public awareness campaign about some of these issues, some of the resources that are available from IEHP, from Molina, from the Latino Commission. I think that might be a really good next step, is to just, raise awareness amongst the group and our community about what is happening.
Hemos tenido una hora muy ocupada en animando a las personas que apliquen para la Medi-Cal, pero ahora necesitamos darles a conocer las aseguranzas que les cubre lo más que se pueda, porque por ejemplo hay aseguranzas que no les cubre el dentista o que nomás les cubre la revisión, no les cubre más que el examen médico y no los lentes. Entonces eso es importante, porque si nosotros estamos hablando que apliquen para su Medi-Cal, pero también queremos que ellos aprovechen lo más que se pueda de las aseguranzas, porque han tenido un largo tiempo sin examen físico. Entonces ahora que ya pueden, de 26 años o más, que apresurarlos o animarlos que vayan a tomar sus exámenes físicos, pero también saber qué es lo que cada aseguranza les está ofreciendo.
And Esperanza brings up a really good point that she would like to see now there's this huge push with Medi-Cal, the Medi-Cal expansion that happened January 1st for folks that are undocumented. And then also folks that are just enrolling into Medi-Cal to know exactly what are the different health plans offer, and what do they cover? I think, because, as you mentioned, there's some, health plans that do cover vision, some that cover dental that don't, and there's some differences between the different health plans, so they would find that information very valuable because they are out there in the community enrolling community members that now qualify for Medi-Cal into these, into Medi-Cal, but then they would like to have the additional information so they could share with the folks of this is like a health plan and they offer you X, Y, and Z. Then the next, health plan offers you A, B, and Z. So it would be good for them to have that information. Yeah. Good. Buen punto.
También porque mucha gente que ya tiene Medi-Cal piensa que es nomás de emergencia. Que no, más de mi comunidad, piensan que es nomás de emergencia y que no les cubre, pero ya les cubre porque usted ya califica para toda la cobertura que usted ocupa, dice, no, pero me mandaron de emergencia.
Sí.
Muchos no saben que tienen ya completo el Medi-Cal.
Yeah, and a lot of, another thing too is to, raise awareness on the fact that the new Medi-Cal enrollment is not an emergency Medi-Cal.
Right.
It's a full service Medi-Cal that they now have, full scope. So now they're able to receive, much more services than an emergency Medi-Cal will qualify them for. So that's really good information to let them know as well. So I think it's raising awareness about the Medi-Cal, expansion, the different services that the different health plans provide, where to go, like the Indio facility, that's a great one. And I know IEHP definitely has a lot of representatives here locally that come out, and we do partner with Gabby and other folks that are out here in the region, to give us that information. But I think, maybe having some kind of brochure, pamphlets that we could share with the community health workers as they're going out and doing outreach to raise awareness about those different topics will be very beneficial for them. Last thing, and then I know it's, we'll go ahead and stop at
Yo
12:10.
nomás quería hacer como una recomendación a las dos aseguranzas que están aquí, porque hablé con una persona que tuvo que cambiar la aseguranza porque su proveedor le iban a hacer un examen médico del estómago y su proveedor estaba muy fuera de aquí, como a 2 horas. Entonces tuvo que cambiar de aseguranza porque la aseguranza que ella tenía no le cubría. Entonces a los proveedores, por favor, abarquen o impliquen o permitan que los locales que están aquí cubran sus aseguranzas para que la gente no tenga que cambiar o no tenga que ir muy lejos, porque el raite que les cobran es más de $200. Por ejemplo, si los llevan a Loma Linda, les cobran $200 por llevarlos porque una aseguranza aquí cerca no le cubrió.
No, sí le entiendo acerca de eso, y una cosa para aclarar es que por si acaso uno tiene que ir a un lugar lejos por cuestiones de, pues no se sabe, ¿no? Las aseguranzas, IEHP como Molina, ofrecen lo que es transporte. Entonces, eso les podemos ayudar, es simplemente comunicarse a una línea telefónica y nosotros, eso es algo que es gratis.
Está bueno saber.
Yeah, so
Otra cosa que hacen es también, cuando te renuevan el Medi-Cal, te ponen, por ejemplo, tenemos doctor en Meca, y ya te llega el Medi-Cal y está hasta pan Street, y sin decirnos por qué nos cambiaron eso.
Sí, eso, inafortunadamente eso pasa, pero también las personas pueden comunicarse a una línea telefónica donde pueden hacer un cambio de médico por cualquier motivo. Y en este caso, pues es obvio que uno
porque hay
necesita
mayores que no
cambio.
pueden ni comunicarse. Gracias.
Perfect. See, yeah, so I think, and just the conversation that we were having here, sorry folks that are online, is just, about, very specific cases on, when folks enroll into Medi-Cal, when they get assigned a specialist, they have to travel very far. But Alex from Molina said that, the health plans do provide a transportation service if they're a specialist or their medical provider is not in the region, that there are those resources for folks that need transportation out of the Coachella Valley. And also, Domitila expressed a concern about when folks that are now getting enrolled into Medi-Cal, when they get assigned a primary care physician, normally they get a primary care physician that is not in their community by default, but then Alex once again shared that they could just call it, their 1-800 number or their 188 number. And then they were able to make those changes, at any given time for any reason, to get a primary care physician closer to their community. So really good information. I think that goes under the umbrella of just knowing exactly where to go to, who to call, and the differences between the two different health plans. So I think that's a little bit of information that we want to share with everybody. Anybody online, any last comments, suggestions before we close for today?
Alejandro, Kevin, I just want to thank you for hosting and all the hard work you and your team did to make the meeting today a very good one. Thank you.
Thank you, Kevin. Yeah, it's a collective effort. Victoria, provided a lot of support. Janice also with the IT help. So thank you all for participating. Thank you to our presenters that are here in person and online. So thank you. And we will have a follow-up email with the PowerPoint presentations that we had shared today, and also a recording of the meeting itself, and also the questions. A summary,
A summary of the discussion and the
summary of the
questions and the
discussion.
next steps.
Perfect. Well, thank you all for, hope you all have a great day. Stay dry. Hopefully that huge thunderstorm doesn't impact you all too much. So thank you all for joining us. Have a great rest of your day.
Thank you, everybody.
Bye, everybody.
You.
Have a good
Bye.
day. Thank you.